Let's come to the diagnostic triage. What types of the back pain we can have? There are 4 types. Patient comes with these 4 types of the back pain to us. Number 1 is a simple back pain or lumbago. Second is nerve root pain, or we call it sciatica. Third is the serious spinal pathology. And fourth is the spinal emergency or cauda equina syndrome. So these are the 4 types which we can choose. And fortunately, the 95% patients are from this type 1, back pain or lumbago. Less than 5% are in the second category, like sciatica, and less than 1% is in these two, spina, cauda equina syndrome, and the serious spinal pathology. Simple back pain. It is axial pain, which is musculogenic or muscular pain and mechanical in nature. And it varies with the physical activities. And it affects the lumbosacral, buttock, and thigh only. It don't go below the knee. And the common age group is between 20 and 55. In this age group, the back pain is mainly simple back pain, which is mechanical in nature. And patient is well. They don't have any other symptoms like a fever or any other symptoms. And prognosis is very good. It's 90% of the acute attacks settle within 6 weeks. And 60% of the patient has recurrence in the next 1 year. And recurrent attacks do settle in 3 to 5 years. So these recurrent attacks are also, as I mentioned before, due to our lifestyle. If our lifestyle is better, even these recurrent attacks will not come. Mechanism is a muscle strain and disc degeneration. So this simple back pain is the result of the muscle strain and disc degeneration. So you can imagine that if we receive these patients, so 95% have no neurological deficit, no neurological involvement, so we can treat it conservatively and with other methods of the lifestyle. Second, specialist referral is not required. If there is any general practitioner listening to this talk, so they should not refer this patient to the specialist. They should treat themselves. Second is the nerve root pain or sciatica. That is also called as a neurogenic pain or unilateral. It is unilateral leg pain and usually dermatomal. Peripheral or neurogenic radicular pain, as I said before, you may have the pins and needles and numbness in the same direction of the nerve which is compressed or which is irritated. There is a difference between compression and irritation. I will come later on. And radiates to the buttock, posterior thigh, or foot. In first pain, simple back pain, that pain doesn't go below the knee, whereas in this case, the pain goes down to the foot. And less than, as I said before, that less than 5% of the patient comes in this category. And prognosis is reasonable if no severe deficit. 50% recover in 6 weeks. As in a simple back pain, 95% patient recover in 6 weeks, where in this case, 50% patient recover in 6 weeks. And recovery rate is slower than simple back pain, as I said. Specialist referral if not settled in 6 weeks. So if you are treating this patient and it's not settling, then you should refer this to the specialist, that he should do some investigation that why this pain is not subsiding. As I said before, specialist referral not required unless signs of the severe or progressive weakness in the lower limb or reduction, red signs. Number 3, third type is serious spinal pathology. That if below the age of 20 and above the age of 55, if you have back pain patients, so you should not take it lightly, because below the age of 20, there is no mechanical back pain, but there are other causes, like maybe starting scoliosis, maybe Sherman disease, maybe the spondylolysis, which is sometimes congenital, sometimes acquired. It's a breakage of it's a fracture due to spondylolysis. And above the age of 55, there may be carcinoma or tuberculosis or osteoporotic fracture or whatever. So in this group, if below 20 and above 55, if you receive the patient, do not take it lightly. Investigate and find the cause. And it's non-mechanical pain, meaning pain is present all the time. And mostly it is thoracic pain. In the past history of the carcinoma or steroids or HIV, you can explore in the history taking. And patient will be unwell or maybe giving the history of the weight loss and maybe the structural deformity as in case of the TB, spine or any osteoporotic fracture. But fortunately, this group is less than 5% of the patients comes in this group. Red flags. What are the red flags? If there is an infection and fever with a back pain, IV drug users, HIV, tumor or history of the cancer, history of the steroid use, and trauma such as fall or accident, and Cordova-Equina syndrome in which the bowel and bladder symptoms will appear. Specialist refer is mandatory and recommended. The tests are needed to make the diagnosis and the specialist will treat the cause. If it is cancer, or if it is osteoporotic fracture or whatever it is. And before sending to the specialist, you advise the rest for a couple of days or until he has seen the specialist and do the investigation to rule out any cause. Number 4, the fourth type is spinal emergency. It is Cordova-Equina syndrome in which the bladder dysfunction, bilateral leg pain, lower extremity weakness, saddle anesthesia, poor anal tone, and maybe foot drop. If you see these signs, this is an emergency. You can't wait or you can't rely on the conservative treatment. You send the patient immediately to the nearest emergency or nearest orthopedic or spinal surgeon. And this Cordova-Equina syndrome can be due to the huge prolapse disc. Normal prolapse disc may not cause this, but if there's a huge disc which put the pressure on the spinal cord and may result in the Cordova-Equina syndrome. Second is fracture, and third is cord compression tumor. So these are the three causes of the Cordova-Equina syndrome. Cordova-Equina syndrome is an emergency, and it is specialist consultation, immediate and urgent. Even in the middle of the night, you ask them to go to the hospital that they start treatment. It requires urgent surgical decompression. Is a primary absolute indication. It's an absolute indication for the acute surgical decompression of the lumbar disc herniation.